You're listening to Consolidate That. Ukraine is my motherland. It is now under a savage attack by Russia. Ukraine is shielding Europe and the rest of the civilized world from Putin's barbaric aggression. Ukrainians are brave and effectively fighting back. Let's help. Make a donation to Armed Forces of Ukraine. Link is in the show notes. #StandWithUkraine.
Welcome back to Consolidate That, Ivan. It's a great day. We're recording the day right after Halloween, and it's nice to see you recovered from all of your zombie bites that afflicted you yesterday. And I'm looking forward to seeing what sort of cool stuff we're going to learn from our guests today.
Yeah, I'm glad to see you too. Still wearing your costume, or is that not a costume?
I see you have on your bald cap. Oh no, wait, it's just natural.
All right. With that, I'm very excited to have our guest today because this is a repeat guest, and he is always into the new projects and always on the front of the innovation in our industry. So I'm happy to reintroduce Andrew Schultz. Andrew is the Director of Business Development and Clinical Services for Midmark Animal Health and Project Director for Midmark Academy. He currently serves on the board of directors for the Foundation for Veterinary Dentistry as the representative of industry. Andrew started his work at Midmark as a director of monitoring and critical care following the 2008 acquisition of Schultz Veterinary. He was president and CEO of Schultz Veterinary. He holds a master's degree in business administration with an emphasis on marketing and entrepreneurship, and began his career as a CPA with Arthur Andersen and Company. Andrew, welcome to the show again. Thank you for coming back.
Thank you. Great to be here.
So you're doing all these cool things in dentistry, and that's one of those areas that for me stayed the mystery after graduation because we never learned about dentistry in vet school. Surprise, surprise. And then leading to me being passionate about critical care, still didn't learn anything about dentistry. So that's why that's a big black box for me. And that's something, thank you for developing that in our industry. And as we talked about it last time, you sort of have this end-to-end process to implement dentistry in the clinics, from just an idea to, the equipment, to training, to marketing, like the whole sort of end-to-end workflow. Now, one of those things that I know that I wanted to jump in now is that reportedly the most difficult thing for development of the dentistry is not even training the teams, because that's also a problem, but actually selling it to the pet owners. And the biggest fear and the difference between the regular dental once a year, twice a year appointments with your regular dentist is anesthesia. So is that still a problem, and how do you overcome that?
Yeah, absolutely. Last time we were on the podcast, we talked about building a successful dentistry program and like you said, training the entire team. But fear of anesthesia is actually listed as the number one obstacle or objection that pet owners have once they get the recommendation. Of course, we talked last time about, first we got to recommend dentistry, but once it is, people are worried about anesthesia, and some of that is because a lot of times they're not heeding or getting the recommendation until the pets are older with a lot of oral, issues, but also just because of general experience in, their interactions with their pets and their veterinarians as far as the anesthesia goes. And the flip side of that is, I believe that some of the issue is that many of the clinical staffs and teams in veterinary medicine aren't that confident in their anesthetic skills. It's an area of stress and anxiety for them, and because of that, their recommendations aren't as strong as they could be if they, had their skills and competencies shored up in that area.
So, I remember my conversations, and again, it's a different pitch. I always talk about, if I were to refer to our vet medicine as the sales process, which I think it is, everything's a sales process. When I was in ER, that was the least of the concern, because when you have a hit by a car with a bleeding abdomen and chest simultaneously, the worry about anesthetic as the part of the process of fixing it is always like, we have to do it. Now, here you're doing an elective procedure and you're making recommendations. So I assume that paramount importance to make and to get there with the comfort with the blood work. But then also, what is that pitch? Because I know that usually general practitioners, when they're talking about spay and neuter, there's a big conversation about anesthesia. What is that talk track that the technicians and the doctors can feel more comfortable pitching it and then not making it such a big deal, especially if it's a young and healthy pet? What do you recommend in this sort of program that you roll out to practices?
Well, it's interesting you bring this up because, one of the challenges we have in making that paradigm connection with the with the pet owner is for them, when you go to your dentist, you sit there in the chair and you hold your mouth open and they do their business and they're done. But our patients aren't compliant in that way. They can't keep their mouths open for an hour, and certainly aren't going to let you, probe and chart and everything that needs to be done. And so that's why it's necessary to have that conversation about anesthesia, because these procedures, especially when you're talking about what's now known as the core procedure, the comprehensive oral radiograph evaluation. In other words, because 70 to 80% of the anatomy of the teeth is under the gum line. Disease can't necessarily be detected visually in the exam room, and that's why it's important to have that annual core procedure, so that we're going to not only clean and probe and chart the mouth, but we're going to take dental radiographs, and all that has to be done under anesthesia. And so the practice team is, when they're trained in dentistry properly, when they've been through one of our programs, certainly, or others where they are confident in their dental skills and are following best practices in that area, that's all part of the conversation. But oftentimes when the pet owner brings up the anesthesia discussion, it's a matter of how that practice team is trained. And unfortunately, what we've learned over the years is most, in terms of the general practice, most veterinary technicians perform as the anesthetist, in that procedure. So that, the doctors are managing the overall pharmacology, the drugs, all that sort of thing. But when it comes down to actually implementing the anesthetic management of that patient during the procedure, monitoring, hands-on monitoring, charting, and everything else, that's the technician team. And in our research and just through observation and just common knowledge in the veterinary industry, most of the technicians are trained on the job. They learn on the job there. And even those that are credentialed, there was a study that I looked at, was a survey of credentialed veterinary technicians around their comfort in monitoring, an anesthesia. And even the credentialed technicians wish they had more time in school learning about how to overcome anesthetic complications, how to respond to the patient alarms that are going off. And that's something that we're attuned to, because as part of Midmark and supporting our anesthesia monitoring equipment, we employ a clinical support team. So these are highly trained technicians that still do relief practice in emergency clinics, that are able to troubleshoot problems, over the phone. And they literally take thousands of calls a year when people have questions or trouble with their anesthesia equipment. And oftentimes, in fact, we've been tracking this for the last 2 years scientifically. More than 75% of these calls could have been avoided had they been following a simple checklist. For instance, if we go back to the 2020 anesthetic guidelines that was published by the American Animal Hospital Association, it was focused predominantly on how to avoid adverse events through using checklists and making sure the teams are properly trained. And so that's where we began to merge the idea of our entire team dental training and the idea of training everybody in anesthesia. So we have a level set baseline of competency and confidence in anesthesia monitoring, so that when they're making those dental recommendations to the pet owners, if somebody has a question or a concern about anesthesia, they're prepared to address that, talking about the best practices that they follow and the protocols that they follow in anesthesia monitoring, to make sure that those pets are kept as safe as possible during the procedure.
So, Andrew, earlier, I think you mentioned sort of at the beginning there the concerns that come from the pet parent. And I'm not a technician. I don't think anyone should go under anesthesia by me under any situation. Even if you trained me, I wouldn't trust me. But as a pet owner, I find that a lot of times my comfort comes from sort of the confidence in the provider. How do you think that the training that you all do and the communication skills that you give the technicians and the teams translates into that confidence to the pet owner?
That's a great question. I think it starts with, and I'll tell you where we started after taking those calls, tracking what was the common issues that people have when they call in, and these are people using our anesthesia monitoring equipment. We discovered that like I said, 75% of them could have been avoided by using a checklist. Checklist and the AHA guidelines. Our team actually built in a proprietary checklist into our latest vital signs monitor. So a lot of people, will survey them and we'll talk to them in, at the trade shows or in practice or whatever. We'll ask them, are they using checklists? And some do, some don't. Some have a checklist, but they don't always follow it. So we built one into the monitor so that when somebody starts an anesthetic case, it just pops up, and we use it as a closed loop communication tool. More than anything. So, did you do a leak test? Did you reopen the APL safety valve after the leak test? Did you check your oxygen level, and so forth? And these are common issues that, unless you're following a checklist in the busy, chaotic environment of a typical veterinary practice, could easily be missed or overlooked. And so those, that's kind of where it starts. And so about 5 or 6 years ago, we decided that there was only so much we could do over the phone when we were handling these calls, and we began to look for ways that we could develop best practices training. And the first training that we put together was we got the slide deck configured, and it was like 150 slides on best practice for anesthesia. And that's when we realized there's a lot, and we went in and piloted a couple of these, and it was just way too much. And we realized, because of the varied experience levels of the staff, even an individual clinic, we had to dial it back to really the foundational basics again. So the first step was to, and the first half-day course that we came out with was it was anesthesia monitoring 101. It was all about the operation, the maintenance, and the troubleshooting of the anesthesia machine and the monitor itself. Because a lot of the problems that we see, when somebody's, and we still get calls, every week, how can I turn off these alarms permanently? Like, which alarm is going off exactly, and why are you wanting to turn it off? A lot of those alarms are set off because of failure to maintain the anesthesia equipment, or something they missed in the anesthesia equipment that ends up working its way through the patient, unfortunately, to a point where then a patient or vital signs alarm is going off. So that's where we started. So it was like, let's get that handled first, and then we introduced a second half of the day, which is like anesthesia management 201, which is more about the pharmacology and actually troubleshooting those alarms when they go off. But when we discovered the simulation training, it took us to a whole new level. So if you'd like, I could tell you a little bit about that.
Well, that's kind of what I wanted to probe. So from my selfish sort of Galaxy Vets wearing hat perspective, if you're out there, a veterinarian that is about to shop the equipment, and you go and you buy, anesthetic monitor from someone, they may not know how much of other things that Midmark does and your programs. So what is available? So the way I'm thinking about it, we're partnering with new clinics, and the anesthesia, as you said, all over the place, from excellent to not so much, different equipment, turned off alarms on the monitors. I love that, by the way. Yeah. How do you take the batteries out of the smoke detector? That's what you're doing. So so for those that don't know how these program works, and for those that are building maybe a group like we do, is there an opportunity to partner with you at the time when we are buying the hospital or partnering with the hospital, to actually do this sort of check over what is our anesthesia practices, and how do we implement it? Is there a service that Midmark provides? And if we see the gaps, to create those standards of care that you already have a wonderful program for, how can we leverage that as the consolidator when we have rapid partnership with hospitals to bring those standards up to the level? Or is it just buying a monitor? That's the only thing that we can do, and then get all those programs. Like, is it
No. Well, I
contingent
mean,
on that?
you're talking about a fairly unique situation. I mean, obviously there's other groups like yours that is, that are acquiring hospitals. And I think, we talked about this last time with the dentistry opportunity, that I think it might be a valuable evaluation as you're going into that partnership, just to understand where they are and what might be needed to, bring them up to, a level we're all confident with and comfortable with, as far as the anesthetic care and monitoring and equipment and training and whatnot. And so certainly the things that we build into this monitor, besides the checklist, there was another thing. We get calls all the time about the soda lime. People will ask, like, or we'll ask them, like, when was the last time you changed your soda line? Because if they're monitoring end-tidal CO2, they'll be able to see that, and we'll get calls like, hey, this is reading really high. And that's one of the first questions we ask, did you change your absorbent? And we'll get responses like, well, yeah, we change it when
What
it
is
changes
soda lime?
colors.
What is
So
soda
yeah,
lime?
soda lime is an absorbent material that scrubs in a closed circuit system, closed breathing system. It scrubs the CO2 out so that the patient is not rebreathing that CO2. And so but it has and we learned this, through the calls that we were getting, and we connected with the manufacturer of the substance. It's got a 2-week shelf life. And so,
Really?
each
I
anesthesia
didn't know
machine
that.
manufacturer will have a prescribed frequency of changing that soda lime. And for the Midmark matrix machines, it's 8 to 12 hours of anesthesia time. And so, supposedly the practices are supposed to be keeping track of that anesthesia time. Oftentimes they'll have a tape or a label or something on the machine that will have a date and a time, so that they can keep track of when they need to change it next. On average, a general practice, under average surgical procedure time during the week, should probably be changing it weekly. But when we ask, a lot of people, they're like, oh, we change it monthly, or we wait. And now it has a reactionary, at least the brand that we use called SodaZorb, um, reacts to that chemical uh, exchange by turning a purple color. And so, and that's, kind of a known property of this substance, so that when, somebody's using it, we'll ask them, like, when do you change it? So we wait for that color change. What many people don't understand, though, is that color change is temporary. So that just tells you that it's absorbing the CO2 in process. But after a day or two, it reverts back to the normal white color. And after 14 days, it's totally desecrated and will not absorb anything else, but it also won't change color again. And so, you'll have people that will want to buy soda lime in large 5-gallon containers for economies. It's going to be cheaper when you buy it in bulk that way. But what they don't understand is once they crack that lid, they've got about 14 days before the ambient air reacts with that soda lime that's remaining in that tub, and it's desecrated after 2 weeks. But they might not know and keep using that. And if they're not monitoring end-tidal CO2, which a lot of, probably, I don't know, 25, 30, 40% of the practices still do not monitor end-tidal CO2 routinely, they won't know that their patient is rebreathing CO2. And so, it's one of those messages we get out. So what we did on this new monitor is we built a reminder, a weekly reminder. Just pops up, hey, did you change your soda lime? Do you have fresh soda lime? So, that was another tool that we built into the monitor to address something that's very common and not well known as far as how that operates.
But for the program, so you have this sort of program of anesthesia simulation workshop. Is that something that any practice can contact Midmark and say, can you run this shop, and there's a fee associated with it, or how does that work? How do you roll it out?
Yeah. So, well, let me tell you a little bit about the background from it. So, again, one of the challenges you have with, practice teams that are learning on the job, or even veterinarians that graduate from vet school, unless you're talking about a lecture, on how to overcome anesthetic complications, it's really difficult to simulate real life experiences. And so the challenge there is then people end up learning those things on people's pets, and no bueno, right? And so an anesthesiologist, Dr. Robert Keegan at Washington State University, was trying to come up with a way, and he's a computer tinkerer, and built a simulated program that would allow the operator to manipulate the readings on a mock anesthesia monitor screen in response to student actions. And he created a pilot program for them to teach anesthesia and overcoming anesthetic complications, responding in kind. And this was like 5 or 6 years ago, and ended up uh, after 2 or 3 years of just everybody signing up for it because it became so popular, they just built it into their second year program. It's like I think a 12-week simulation program. But I've been in contact with him for a while, and he learned how to take it on the road. A local tech program asked if they could, see how that would operate, if he could do a lab for them. And when he did, the light bulb went off, like, how we could take this in clinic like we do with with the dentistry program and train entire teams this way. And it started by first we sponsored Dr. Keegan's simulation labs at IVEX. In fact, the last 3 years we've sponsored him at IVEX. This past year, we sponsored his simulation lab at the Dental Forum, and again at AHA Connexity. I think we did last year as well. So the interesting thing there is they'll have a lab that goes in the afternoon. There's like 16 participants. They're just ad hoc people that have signed up for this lab that attended this conference. And just watching this, the participants get into groups of 4 and they go through these scenarios, the anesthetic cases, is really eye-opening, because when they suspend their disbelief and they've got the stuffed animal in front of them, but they've seen this monitor and they're pretending it's real, when they start sweating, their heart rate goes up. You can tell they're like, as they're presented with these different anesthetic cases. And my message to them at the end as a sponsor of the program is like, hey, as cool as you thought this was here, imagine being able to bring this back into your clinic and doing this with your entire team. Because again, it's about that teamwork in a practice, between the veterinarians and the technicians, being able to communicate properly, knowing everybody's roles, and just level setting that that anesthetic skill set and knowledge, so that everybody's working as a team together, the same goal. And the cool thing about the simulated environment is you could try things, you could make mistakes. One of the other primary rule besides suspending disbelief is Vegas rules. So what goes on in simulation training stays in simulation training. And so you have, new staff or even experienced staff that, just hadn't encountered a certain situation before. If they don't know, they could say, hey, why don't we try this drug? Or why don't we try responding in this way to what they're seeing, with the vital signs and some of the other things that are going on. And the operator could then show them like, hey, if it was a wrong decision, this is, either the patient's improving, and or getting worse. And they could even pause and stop in the minute. I mean, you can't do that in a normal day-to-day surgery case. If something's going on and you don't know how to handle it or what to do, you can't like pause and say, okay, let's, I mean, there's a patient in the balance, right?
In computer games, you can't save and restore.
That's right.
You lose.
Exactly. Yeah. Everybody gets one life in this one. So
That's right.
yeah, so that's been really exciting to see that. And so yes, we've kind of combined what originally was the half day and full day anesthesia monitoring 101 and 201. We put a little bit online, so we have some kind of level set modules ahead of time before we come in. We do a survey ahead of time to find out how that practice is operating, what equipment they have, what drugs they use, so that that training could be customized. And that's what's great about the training too. We validated it with Dr. Keegan and the other founder of the software design company that built this simulation program is Dr. Julie Noyes. She's a veterinarian and a PhD in psychology, but the emphasis was simulated learning environments. She was the previous chief learning officer for AHA, then went on to VetBloom, and now she's with the AAVMC, working on competency-based veterinary education. And so super cool. We were able to partner with them and sponsor a validation study for this software. And in this case, we went to a local tech program here at St. Pete College, and we started with a group of 8 novice technicians. They had never done anything with anesthesia before. They were just getting started in their program. And we took them through a 3-part kind of pre-test. So they did a knowledge test on how to overcome certain anesthetic complications. They all failed. Their self-efficacy. So how do are you confident that you can do these things? And of course they were not very confident because they had never done them before. And then we took each one by one through these 4 simulation scenarios. And I mean, several of them were so nervous going through it that they almost got sick right there. I mean, it was like super stressful. We expected that they wouldn't do very well because they had never been around it, and that was fine. And we tried to prepare them for that up front. But anyway, what we did then was we took them through this 4-hour simulation training. And that's where we go through. Dr. Keegan or one of our trainers takes them through these 4 different cases. 4 people work together as a surgical team, and they're presented with various common anesthetic complications: hypotension, hypercapnia, cardiac arrhythmias, trouble with the anesthesia equipment. And as they're working their way through, 10 or 15 minutes through those, decision points and trying to overcome that, um, you know, the operator could respond by, making the vital signs change according to how they're responding. But the key part of it is afterwards, then there's a debrief where we gather together as a whole team then and go through what did you see there? What did you experience? Why did you choose to do that in response to what you were seeing? What could you have done differently? That's where like 90% of the learning happens, is in that debrief. And they took them through that, those 4 scenarios, and then a week later gave them the 3 tests again, and they all passed flying colors. I mean, they measured a huge increase in competency and confidence in those areas. It was really cool seeing some of the ones that were almost sick the first time were like, we got this. They were right there doing what they needed to do. And again, those scenarios that we built were based on things that people see commonly, during elective and other procedures in a general practice.
Wow, that's definitely powerful, especially those scenarios. I remember my favorite thing was when I was an ER vet, having a new grad technician do a surgery with me,
Hmm.
and I would create all kinds of scenarios for them on a live page just to see how they feel about it.
Right.
It was a bit unfair, but it was a lot of fun. I do want to circle back. So I think it's really cool. So on the front, you're equipping, the team with a checklist that they should look for.
Mhm.
And then on the back end, you're training them with the scenarios where things go wrong. So I think that combination should be very powerful. And I might be jumping into, I think I'll be jumping into your recommendation on the book, but how did you come up with the idea of the checklists?
Well, I mean, that was it was funny when we launched the monitoring, the new monitor with those checklists built in. I ordered the checklist manifesto book for all of our sales teams so that they understood. In fact, Atul Gawande, the author, was supposed to be, he was the keynote speaker at the AVMA meeting in 2020.
Wow.
I was so excited to go, and then COVID happened and it went virtual, and I
Oh,
didn't get to see him, but I was going to have him sign the book. But
oh my God.
yeah, I mean,
That's
checklist, and simulation training for that matter has been used forever in training, airline pilots,
yep.
military operations. Even human healthcare uses simulation. In fact, that's where Dr. Keegan first got his idea for it, attending some of the hospital trainings in the area up in Seattle. So, there's a huge connection to that checklist, and that's I had I think that the interest was late, and I had read the book years ago, and then when I saw the AHA guidelines come out, and then I remember we were watching Dr. Tammy Grubb, an anesthesiologist, and Jen Sager, who's a VTS in anesthesia. They were part of the team that helped write those guidelines. When we saw them introduce that to the AHA conference in live, I remember one of my teammates counted, they said the word checklist like 20 times. I mean, it was like, okay, I think this is important. And at that point, we had already, because we knew, ahead, sponsors of that at the anesthesia monitoring guidelines, we knew what was coming, and we just felt like we just needed to build a tool in to help prevent those, situations from happening.
That's so cool. That's like one of my favorite books. And, it's just such an interesting thing with this simple checklist. And we implemented that. I don't know if you remember, but in SmartFlow, we had that idea. So essentially, a lot of the stuff was incorporated into SmartFlow for the anesthesia purposes. So we had these tasks and then subtasks that were sort of checklist items for pre-surgical preparation before you cut. And anyway, it's just such an incredible and simple tool. And I'm really happy that you incorporated that. So we want to stay true to our listeners and the length of our episodes, so we're just in about that time. So our question that we always ask for from our guests: what kind of book would you recommend to our listeners?
Well, that was it. Checklist manifesto, I would say we covered that one for sure.
Yeah,
So
no,
that's
yeah, thank you.
I want to ask when I can sign up to do this simulation.
Sounds exciting.
See how
Right
many
away.
You're a
lives
Hey,
I
novice
maybe,
technician.
yeah. One other thing I was going to add about the simulated, because I talked about the validation of the brand new learners. The great thing about it is so customizable. You could take it to an experienced staff too. So we had a boarded veterinary dentist, Dr. Jamie Burning in Ohio, who ordered the training for her team. She has a VTS dental specialist, a VTS anesthetist from Ohio State, and a staff that was, veterans of 15 years, a technician. And we brought that in. Our trainers were able to, through that pre-training checklist, kind of gauge their experience level and modify. So they, in the middle of the case, they could throw, curveballs in, and challenge even experienced staff to overcome things. So that's been really cool.
Yeah, and sometimes I think if you have experienced staff that is overconfident, that initial test for them might be a little bit of a curveball to throw on the team, and see there, because they could be super confident but not necessarily super competent. So
Right.
so, and that's, I think that would be an interesting program to actually introduce, just like I said, for the groups too, if you want to up your standards of care, and then lead with that, especially anesthesia. That's like that is the place where pets can die, so you can't undermine the validity of that. Well, Andrew, thank you so much. It's always a pleasure to have you here. You're always on the edge of developing some cool stuff. I'm hoping they will soon partner more on doing these things in Galaxy clinics. That's something that I'm looking forward to, and thank you for finding the time.
You bet. Thank you very much. It's been a pleasure.
Thanks, Andrew. Bye-bye. Thank you so much for listening to Consolidate That. If you want to hear our new episodes, please find us on any podcast platform. Also, you can learn more about us on our website at galaxyvets.com.